First of all, everyone did great. I was very, very pleased. Um, I want to go over these each one, and I will bring up codes that might have been used and why we shouldn't use them. But we're even though it was a great results, I think it's important to cover them so that if any of us have any questions that we can ask those today. The first one was a radiology report, and I mentioned up here professional coding for the radiologist. This is a CT abdomen and pelvis with intravenous contrast. There was no oral contrast. This patient has a history of pancreatitis and generalized abdominal pain. Okay, so we see the technique here is intravenous contrast material only, and that was important in our selection of the radiology CPT code. The findings, I'm not going to read the entire report, but I have went through and highlighted the factors that we would pull out in our review as we're looking at this so that we would understand what we needed to code. We found at the gallbladder a 4 mm non-calcified structure, which appeared to be a small polyp. So we're going to make a note of that. No other abnormalities seen, no dilation, everything was good. The pancreas, there was nothing identified. And remember, our diagnosis here was pancreatitis. Okay. If we scroll on down, we're looking at proximal small bowel loops are present, but there's no inflammation, there's no thickening. So unremarkable means no significant findings. Here we have the radiologist made mention that this patient, there's a post-op change with staples in the expected location of the appendix. So we're pretty sure that the patient had an appendectomy. Long time ago, apparently. Nothing here to report. It's just a finding in the x-ray that the physician makes note of. All right, so the pelvic organs are unremarkable except for a mild enlargement of the prostate. Still, there's no mention of any treatment. It's just a finding. And there is mild atherosclerotic disease. When we see atherosclerotic disease, atherosclerosis just means hardening of the arteries. So we don't have anything definitive here. We don't have any follow-up treatment. We don't have a diagnosis in our pre-existing diagnosis. And when we get to impression, we don't have a mention of that either. So we would call those comments that the physician, the radiologist made along the way, we would call those our incidental findings that's addressed in our guidelines. And we're going to look at that in just a minute. So then the radiologist gives us an impression. No acute processes were demonstrated. There's no evidence of pancreatitis or any complication of the pancreas. There is a tiny gallbladder polyp, and then those distended proximal small bowel loops at the left upper quadrant there are non-specific. No other significant findings are demonstrated. So we had a patient that come in with generalized, let me see if I can talk better, generalized abdominal pain and pancreatitis, which is not confirmed in the impression. The two diagnoses that we're going to pick up from this report is the gallbladder at K82.4 And then we're going to pick up that generalized abdominal pain with R10.84 because we do not have any confirmation, any linkage saying why the abdominal pain. So we've got to identify that. And then we'll go ahead and look at our CPT code, which was 74177. That's our CT of the abdomen and pelvis with contrast material because it was intravenous contrast. Okay. And then we've got to do the modifier 26 because what we're coding for is the radiologist. So in this scenario, we're coding our job, we're employed and coding for radiologists. So we've got to pick up that modifier 26. Now I want to look at incidental findings here. And I used our official coding guidelines and I used Coding Clinic, which Coding Clinic you do have access to. And just as a reminder, when you come across any, let me pull up an example because I want to make sure everyone remembers to do this. Coding Clinic is for ICD-10 CM coding only. It's not going to discuss CPT. But let's say that I pull up pneumonia. Remember to always scroll down to articles and newsletters. And here I have 7 Coding Clinic articles. Take the time to read them. This is excellent education, and you have this in Find a Code. So I think it's important that we utilize that. All right, but what's important here is an abnormal incidental radiological finding that has no clinical significance, nor current signs and symptoms for the patient are not to be coded as a condition. And this is the example in our guidelines. Now, when the documentation is unclear in meeting this definition, you would query your radiologist that you're working for to see if it's significant to code. But that's rare. That's rare. Once again, Coding Clinic tells us it is inappropriate to report an incidental finding found on a radiology report when the finding is unrelated to the sign, symptom, or condition that necessitated the performance of the test for a patient being seen in the ED. But that doesn't matter. That's the rule period. That was just from that Coding Clinic Q&A. So what I want to point out here is our findings that the radiologist saw and he made mention of would have been the atherosclerosis, would have been the BPH, would have been the fact that the patient, he saw staples. So the patient had a previous appendectomy. Those are not related to why the patient's here, and they were not documented in the impression. They were only findings. So we would not capture these diagnoses in our coding. And then this is the actual Section 3 of the official coding guidelines for reporting additional diagnoses. They're not coded and reported unless the provider indicates their clinical significance. The findings are outside the normal range, and the attending provider has ordered other tests to evaluate the condition or prescribe treatment, it would be appropriate to ask the provider whether the abnormal findings should be added. This is just a learning curve here because the entire time that you've been coding and every other coder, we always wonder, well, should we add this? Should we not? So if we stick to this will justify our rationale and our reasoning as a professional coder as to what we code and what we don't code. Thank you.
Please, I want to confirm on this particular scenario, which is the principal diagnosis?
Okay. On this, either could be your principal.
Okay.
Because the polyp was identified and the abdominal pain. If I was coding this, I'd probably put my abdominal pain first, but in the rules of the coding clinic, official coding guidelines, either of these could be your primary, because they're going to both link to that CPT, that X-ray code.
Okay.
I hope what we've gone over today, especially those incidental findings, make a note of that, because that's going to always be a question no matter what you're coding, and you're going to have to go back and refer to those guidelines, and then you're going to have to walk through that chart again and make sure whether or not they are of clinical significance, because that's your main focus.